So I'm Shaina Schaetzel. I'm one of the TAC surgeons, and I think you guys are having a series on trauma, and so I get traumatic brain injury. This is an overwhelming topic. There's so much, and so I just kind of lightly touched on a few things. Please stop me at any time if you guys have any questions or want any further clarification or anything like that. Also, everything with a grain of salt. I am not a neurosurgeon, but of course we manage traumatic brain injury a lot. So we'll talk a little bit about the anatomy and pathophysiology. We'll talk about the concepts of primary versus secondary injury and what we can do for each of those. Intracranial hypertension, both assessment, identification and treatments of it, and then also touch a little bit on prognosis. What do we tell the families at the bedside when they're asking us questions? So first of all, starting with epidemiology. So in the US, 1.4 million people sustain traumatic brain injury annually. That's a really big number. And then of 240,000 of them are hospitalized, with 50,000 deaths that are directly attributed to traumatic brain injury. And 80 to 90,000 of these people suffer permanent disability annually. Some of these numbers are also somewhat challenging to assess because even moderate traumatic brain injuries, people who come in with, or people who have bad concussions, just think like there's a lot of people who don't come in. So this is likely a gross underestimate. And it's estimated that 5.2 million Americans live with TBI-related disability, which is 2% of the population, which is pretty crazy. Most common causes are falls, motor vehicle crashes, and pedestrian versus auto, and then assault. Now, this assault, though, does not include suicide. This is, committed by another person. But if you add in suicide, actually assault becomes one of the #1 cause, actually, of traumatic brain injury. So we're talking about the pathophysiology. So traumatic brain injury, it's a dynamic process of primary and secondary injuries. And the primary injury is what occurs at the time of the trauma. It's done, there's nothing we can do about it, and it's what has happened when people come in. It includes the lacerations, skull fractures, what we consider vascular injuries, kind of what we think about the the subdural hemorrhages, the epidural hematomas, and the intraparenchymal hemorrhages and contusions. I'll talk a little bit about each one of those. And then there's also diffuse injury, which are sometimes a little bit more challenging to identify. Sometimes there's imaging abnormalities, sometimes there aren't, and they include concussion, diffuse axonal injury, and subarachnoid hemorrhage. Now, secondary injuries are those that occur after the initial impact. And although it may be difficult to control or intervene upon these, this is where we have our opportunity of intervention. And it starts with bystanders, EMS in the field, in the ER, and continuing on when the patients come to see us in the ICU. Oh, I apologize for the formatting here. But talking a little bit just specifically about some of the primary injuries. A subdural hematoma is one of the most common injuries, and it occurs in 20 to 40% of head injury. And this is when you have injury to the bridging veins. And so you have veins that go essentially from your scalp down to your brain. And when those, they make a bridge. And when they get injured, that's when a subdural hemorrhage happens. Now, seriousness of these are based on the size, how much space you have left in your head, and how quickly they expand. And also these tend to have a little bit more brain injury, brain parenchymal injury than the epidural hematoma, which is what we'll talk about next. Now sometimes you can get these elderly people who have a huge subdural hematoma, but because they already have like a shrunken down brain, it doesn't really mean much. So the size itself, or how severe this is based on a lot of different factors, okay? Whereas an epidural hematoma is a little different, and this is, most of them, about 90% of them, are due to injury to the middle meningeal artery, which is specifically this artery that lives right about here, and it's because our temporal bones are relatively thin and susceptible to injury compared to the rest of our skull. And this is under arterial pressure. And so this is a bigger deal more quickly, and it's mostly due to the mass effect of itself. Because it's under a higher pressure, it can push aside more brain, and these are the ones we want to identify quickly to likely get evacuated. These are less likely actually to have underlying brain injury, and so when you see this, it's a young person, gets hit in the head, they get evacuated, they actually can have quite good outcomes, because if you get that evacuated, they don't often have as much of the parenchymal injury underneath to the brain. So I just wanted to compare again side by side. You can see the arterial under higher pressure pushes the brain aside, want to act on those more urgently. And then the subdural on this side, venous, it's more likely to come to the size of the brain and not necessarily push the brain down and herniate, risk of herniation. And then just again on imaging. Okay. So when I talk about herniation, I know we always talk about, this is kind of the end of the line for brain injury. This is what we want to prevent. And I just wanted to make sure that we all kind of know what we're talking about when we say herniation. So when anything is injured in your body, it swells, right? Like you injure your knee and it swells. You twist an ankle, it swells. You hurt your brain, it swells. But we have this good old noggin, the skull, that unfortunately doesn't allow our brain to swell. And so if it swells too much, it can expand beyond the rigid encasement of our brain. And there's actually 3 different areas. This first one here is subfalcine herniation, and this is when cerebral tissue expands underneath that tough cerebral falx. An injury here can cause further ischemia, specifically often to the medial cerebral hemispheres, and this is often a lower extremity motor problem that will occur. Next, we have the transtentorial or the uncal herniation. This is when your cerebellar tissue, so a little bit lower down, goes, your temporal lobe, so the cerebrum, goes underneath your cerebellar falx there. Now this is what causes that classic blown pupil, because your oculomotor nerve runs right there. And so if your brain swells enough to irritate that, you get that dilated pupil that without not only response, but with a decline in oculomotor movement. And so that's the classic blown pupil, concerning finding for either impending or already occurred herniation. And then finally we have the tonsillar herniation, and that's where your cerebellar or your low down tissue expands. It goes through your foramen magnum. It injures and causes ischemia to your brainstem. This is the one that causes the death, because your respiratory and cardiac centers are of course located in your brainstem. And so this is really, when we talk about brain death and herniation, this is the one that we're more specifically talking about. Often these occur all at once. All right, so we already talked about subdural hematomas and epidural hematomas and the primary injury. And then just finally, of the mass effect vascular primary injury, we have the intraparenchymal hemorrhages or the contusions. And this is just like a contusion anywhere else. It's a bruise on your brain. Small blood vessels inside the brain that get injured. And these are ones that you really have to keep in mind, because first of all, they may not be on imaging immediately, and also they can expand, just like a bruise anywhere else in your body. And so these are those patients that really require the frequent neuro checks, who we really want to get a repeat CT on. And also, because they don't show immediately, this is also why patients, were like, oh, their original scan didn't have much bleeding, but 12 hours later they still aren't waking up, and that's why we resend them to the scanner, because a bruise may have blossomed or developed. All right. Talking about some of the primary injuries or the diffuse injuries, the first one is concussion, which of course can be as mild as a little bit of confusion, take the kid off the soccer field for a little bit, everything resolves in 5 minutes, to all the way to severe cerebral edema and death. The treatment for this is really avoiding further trauma and supportive care. The pediatric, I think it might be the American Academy of Pediatrics, they have some guidelines, as well as the brain trauma injury guidelines about return to play and things like that. You can find them all online for length of altered mental status and all that kind of stuff. Pediatricians are pretty familiar with it. And there's more data in the pediatric literature about this than there is in adults. Next we have diffuse axonal injury. This is a shear injury, and this is because the gray matter and the white matter in your brain have different densities. And so it's just 2 different types of jello. One is more thick than the other. And when your brain stops, or like you get whipped around really quickly or something, one part of the brain moves more than the other part, or stops slower. And the 2 parts, because they have different densities, stop at different speeds. And they cause this shearing injury, or breaking of those axons that are in between the gray matter and the white matter. Now, this is often not seen on initial CT imaging, and if it is, you sometimes see these little punctate microhemorrhages, and this is often more severe DAI. Sometimes you get what they call a loss of gray-white matter differentiation. It's really subtle, but this is a little more white than this part. I'm not great at picking this up. That's why radiologists exist, but it can give you some idea. And so again, these are patients who they aren't waking up in 12 to 24 hours. You can, yes, re-CT them, but really you see this injury more on MRI. And so we will re-CT people, but we wait 2-3 days, still not waking up, look at it on the MRI. And interesting, these imaging, this finding on imaging and this diagnosis is very unpredictable. You can have really severe DAI on imaging and patients do quite well, and vice versa, and we don't really know why. And then finally we have subarachnoid hemorrhage. These are small venous tears in the subarachnoid space. It can be more focal, it can be more diffuse like this. These are also tough to intervene upon. And also when patients come in with medical bleeds, this is where they bleed to, in the subarachnoid space, most frequently. But also it can be traumatic. Not much to intervene on there until they clear out a clot or anything. Okay. So, let's see where we are. We have talked about primary injury, and I think we'll go a little bit into secondary injury. So, patients always have an ongoing potential for secondary injury, and of course this is where we can potentially intervene and mitigate further damage. And so here's everything that can cause secondary injury, ranging from that initial hypoxia in the field, get the paramedics there, get them intubated, all the way to preventing VAP when you guys see them here in the ICU. So how do we care for them? The first is just standard medical management, everything that we do in the ICU. These patients require frequent monitoring, both with vital signs and with neurochecks, essentially to establish patterns. Are we outside the deviation of patterns? So we need to further investigate. Has a brain bleed worsened? Something like that. And this includes, of course, non-invasive and invasive monitoring. We want that head up at 30 to 45 degrees. Of course, the standard VAP and infection prevention, like in any patient. For blood pressure and oxygen, it has been shown that even a single episode of hypoxia or hypotension worsens outcomes in brain injury. Now, unfortunately, by the time patients get to the ICU, they've experienced that, right? Because they're in the field, they're not breathing well. It takes a period of time even for bystanders to get there. So, but still, it's an area for us to intervene upon. And in fact, the brain injury guidelines recommend for a systolic blood pressure of 110 or greater in the acute injury time period. And then, of course, we just want to make sure that the C-collar or their, when we secure their ET tube, that's not too tight. Everything looks good to not compress the venous drainage of the brain. All right, ICPs. So, first, I just wanted to introduce the idea of the intracranial pressure. We have three things inside this heart skull. We have brain, cerebral spinal fluid, and blood. And in general, we all live in homeostasis together. If something is added, oh, I'm sorry, so there they are, and the normal pressure is 10 to 15 millimeters of mercury, okay? Less than 10 to 15. In adults, so this is all in adults, I'm sorry, in children it's lower. Now, if we have a mass or something else that's added there, be it a blood or even if people have brain tumors, for a certain period of time, you can compensate. And so you get rid of some of that CSF, you get rid of some of that blood, so this is a compensated state and your ICP still remains normal. And these are patients compensating when their brain, their monitors still look good. But then you get to a point where that mass gets so big and you have a decompensated state and our ICPs get elevated. And this is where we all start to intervene. So ICP monitoring, the two that we are most familiar with are this fiber optic intraparenchymal ICP monitor, the Bolt, the things that Dr. Holland just comes and puts it in the bedside, as well as the EVD, which is a little bit more invasive. Now, the Bolt is easier to place because you don't have to be in a specific area, you don't have to be right over the ventricle. and it's technically a bit more simple. You don't penetrate as much brain tissue, but you're a little bit more susceptible to measurement drift. You know, we all talk about, oh, it's been in for a few days, it may not be as accurate. And once it's in place, you can't recalibrate it either, unfortunately. So it's there, it's kind of stuck. And also, it's only diagnostic, it's not therapeutic. Whereas the EVD is much more accurate. You can recalibrate it. It's diagnostic and therapeutic, meaning that, yep, I see my ICP is 25, I can drain some CSF from there, maybe it will get better. However, it's more challenging to place because you have to hit those ventricles, and also it penetrates more brain tissue, which unfortunately can increase trauma to the brain, and you can have bleeding along the tract, but everything has its pluses and its minuses. So those are the two main things that I'm familiar with and that I've really seen here as well. Have you guys seen other stuff? No? Okay. Okay, so we talked about ICP being a normal of less than 10 to 15 and intracranial hypertension definition of being greater than 20, and that's when we want to start intervening, okay? And now we talk about cerebral perfusion pressure, and this is why we care about intracranial pressure, and that's because it's blood getting to our brain. And so cerebral perfusion pressure is the blood going up to your brain that we want, good, minus the intracranial pressure, which we don't want high, and that's what we get as our cerebral perfusion pressure. I guess my other things aren't going to come in. So we have an ischemia risk of cerebral perfusion pressure if it's less than 50. So if that MAP minus ICP is less than 50, not good. So we either want to decrease intracranial pressure, increase our MAP, or do both. But we interestingly have pulmonary side effects if it's higher than that. Patients have increased risk of ARDS. And so we don't exactly know what the perfect area is, but the brain trauma guidelines recommend for our ICPs to range in between 60 and 70. So how to intervene? First, we have our very basics, analgesics and sedatives, right? We want to balance our pain and agitation because anything that a patient does to move around is going to increase their metabolic rate, is going to increase their brain power, right? But we also, of course, want to balance it with being able to get an accurate neuro exam and also not giving too many medications to prevent those side effects that can happen with the medications, the hypotension, long-term sedation, and those kinds of things. So we prefer short-acting agents, propofol, fentanyl, and sometimes even Brain Trauma Foundation talks about propofol, fentanyl, and Versed. I'm personally a huge fan of Versed, but it is the shortest acting that we have of our, generally of our drip benzos. Next, we often go on to hyperosmolar therapy. So this is what we're all familiar with. I will state the caveat, though, that the most recent Brain Trauma Foundation recommendations kind of said that we recognize that there is intracranial pressure, we have to treat it, and these hyperosmolar agents might be good to treat it, but there's like really no official recommendations. So we're still kind of going on the old recommendations and just kind of doing what we can. The first one is mannitol. This is the one I would say that I probably use a little bit more often in the trauma bay. And it works in two ways. First of all, it decreases your blood viscosity, and so it actually increases blood oxygen delivery to the brain. Not necessarily blood flow, but oxygen delivery to the brain. And also has an osmotic effect. Essentially, it dehydrates the brain. So because of that, we know that it's a diuretic, and so these patients should have a Foley catheter. We have to use with caution with renal failure, so patients who already have kidney issues, and we also have to monitor the osmolality because it can really prune people out. Obolus starts working pretty quickly and peaks at about 20 to 60 minutes. And then we have hypertonic saline, which works in very similar ways. Dehydrates the brain. Anytime you make anything pretty salty, it dehydrates it. And also this increases blood flow to the brain. It's what we call a rheolytic, which is it's a word where actually it makes, when the blood vessels flow, or the red blood cells flow, it actually makes them stack up on each other very nicely to be in a little line for improved blood flow to the brain, actually. Hypertonic saline can be given as like a 3% drip, or we have our big boluses that range from 3% to the 20 3.4% or something like that. And usually the response is within minutes and can last for hours. Of course, we want to use caution in hypernatremia. We start getting nervous when the sodium is like 150 to 155. But the Brain Trauma Foundation actually says you can crank that up to 160 and not even really worry until 170. And also, of course, this can cause some pulmonary edema if we use it for a long time, so you can be cautious with that. And again, I talked about their official statement is that there is potential need for hyperosmolar therapy to reduce intracranial pressure, but more research is needed for specific recommendations, and there is insufficient evidence to recommend specific doses or agents. So, we don't really know what we're doing. Which is very comforting, right? Yeah. All right. Further, how to intervene. I'm sure you guys have heard about hyperventilation, making someone overbreathe the vent. And the logistics of this is that you breathe faster. You breathe off your carbon dioxide. And actually what happens then is your blood vessels inside your brain constrict, making more space. And so the bad side of that is, of course, it decreases cerebral blood flow to an already potentially ischemic and injured brain. Not good. And so really this should only be used very briefly as a bridge to other therapies. The only time I do this is to hyperventilate someone pretty much on the way to the operating room, because you don't want to do it for a long time. And so overall, the goal is normal carbia with a PaCO2 of 35 to 45, like all our patients. All right, the good old CRANI, which we often consider end of the line after medical management. Again, I am not a neurosurgeon. There are specific guidelines and recommendations of when to do a CRANI, and it has to do with cubic centimeters of blood volume and how much of a midline shift there is, and I don't even know all those. Those are really for Dr. Holland. But in general, I just wanted to talk about the difference between a craniotomy and a craniectomy, and how we differently manage them a little bit, and how they might have different long-term issues. So a craniotomy is really just that focal lesion. And that's also, when people talk about a burr hole, that's what it is. Otomy just means a hole, like a tracheotomy, a gastrotomy, it's just a hole. And what is often done is it can just be drilled down, the lesion is evacuated, the neurosurgeons will tack down the dura again to help stop the bleeding, and then put the bone back on, or even if they don't put the bone back on, it's still just a little loss of a bone flap, okay? So these are not the patients who need the helmets, they don't need another operation in the future, and again, these patients often do quite well because they get the lesion out, it's a small, a relatively small insult, and that's it, okay? So bone removed, lesion evacuated, bone replaced. Craniectomy is a much more serious for the patient. Flap, skull, off. These are the patients who can't lay on that side. They need the helmet when they start getting mobilized. Depending on their recovery, they can come back and get that flap removed, requiring another surgery. And these are often patients who have a larger lesion and they need their whole brain to swell. And so this is where there's a picture here. You see this bone flap is removed, and you see how this brain tissue is all the way out? Yeah, that's not good. But it is kind of what we have. And so these patients are a little more dangerous. And of course, this is when the neurosurgeons come on and poke is it soft? Is it soft? And you know, we're assessing for reaccumulation of blood and for how tense of swelling it is and things like that, okay? So they just have a little bit more of a metabolic,
Don't get queasy.
Literally, is it soft? But they just may have a little bit more of a metabolic insult because it's a larger surgery and loss of tissue.
The total craniectomy, most of the while they were talking about doing that, but studies show that's not.
The bifrontal?
Yeah.
The Brain Trauma Foundation actually does not recommend it at all for anything. She's talking about the bifrontal, or what we call the bucket handle CRANI, where these two flaps are actually removed and they leave this thing in the middle because that's where all your dural sinuses are, and like it's like a bucket handle. Not recommended at all. Yeah. So other considerations, Steroids, right? We think steroids decrease inflammation in anything. Why couldn't it decrease inflammation in the brain? No indication for them. Anti-seizure prophylaxis. Seizures, of course, increase metabolic demand, potentially ischemia, potentially increased intracranial pressure. We want to avoid them. Makes sense. So we have found that prophylaxis can decrease early post-traumatic seizure, which is within 7 days, but it doesn't decrease late, which is why we only give it for 7 days. And interestingly, phenytoin or dilantin, as well as carbamazepine, which I think is Tegretol, are the 2 medications that have been studied and the 2 that are recommended. Keppra has not been studied. There have been no comparative studies. What do we and everyone else use? Keppra. And it's because of the ease of administration and the lack of side effects, okay? Despite it not being studied, it really is the standard of care. And so we continue to use it. But just, again, another indication of we don't fully know what we're doing. Don't tell anyone. Nutrition, we know it's important in all of our patients. We want to start it early. We want to keep it going. Absolutely, we want full feeds by a week. That's what they say, really, we should start within 72 hours to allow some time to ramp up to that if necessary. And of course, stomach feeding is preferred to TPN. Prognosis. This is kind of a different topic, but we're at the bedside. You guys are the ones that the families are coming up to, and how is my loved one going to do? Am I ever going to be able to take them home? Are they going to talk? Are they going to walk? And we don't know. And even with all of this, we still don't know. The brain is a black box. Recovery is unpredictable. But there are actually some tools that are available to help us. They're easily Googleable, and we'll talk about them a little bit. And of course, we have to remember that good is different for everyone. Some people accept nothing less than a driver's license and a job. Some people want nothing more than brainstem reflexes. So we just have to remember that good is different for everyone, and that's where we can really start talking. When we look at these tools and these scales, what we're really using is called the Glasgow Outcome Scale. So we've all heard of the Glasgow Coma Scale. This is just the Glasgow Coma Scale was used to create this. And what the Glasgow Outcome Scale is a range of 1 to 5 of 6-month post-injury outcomes. And it's often separated even more dichotomously into good and bad. And the difference between good and bad is essentially someone being able to live independently. And so it really is that question of, will my loved one have to go to a facility or not, okay? Of course, there's different, things in there, nuances, but those are kind of the big category questions, okay? So the first calculator is based on the CRASH studies. I forget what CRASH stands for, but I think it was like corticosteroids something. This is the big study that told us that steroids do nothing. But other things also came out in it. And this has been internally and externally validated. And it's developed for a diagnostic and prognostic model for both 14-day mortality and 6-month outcomes based on the Glasgow Outcome Scale. And over 10,000 patients with traumatic brain injury were enrolled in this study. There are two different models. There's the basic model where you just add in age, GCS, everything that you see there. And then if a patient has a CT scan, and the characteristics of the CT scan also can be added on to just further give some more ideas into our model, okay? So, again, you can just Google this, CRASH, or any traumatic brain injury prognostic calculators, and you plug in the initial vitals, initial GCS. It's what is the very first recorded. It's not what I'm seeing right now in front of me. And so this is actually a guy that we all know who happens to be in 735. So, 51-year-old guy, injured in a motorcycle crash, GCS 3, intubated in the field. He was always hemodynamically normal. He never had any hypoxia. He never had any hypotension. On his head CT, he had subarachnoid hemorrhage, which is pretty subtle on him, but it's right here. He has no midline shift, which is where they are making this midline, and if you see, the brain is midline, so this edema is not causing pushing over to that side. And we have no mass occupying blood, meaning no epidural, no subdural. And he also had multiple facial fractures, which we call like major extracranial injury. So I popped all of that into the little calculator here, and then this is my prediction. So he has a 20% risk of 14-day mortality, and his risk of unfavorable outcome at 6 months is 68%, which seems really high, right? But you have to think about what this unfavorable outcome is. You look at this guy right now, granted, it's a week out, there's no way he can be independent. And so, you know, at 6 months, he may still not be living independently. And that's really what they say as an unfavorable outcome, remember. And again, no calculator can replace good clinicians and diagnostic, you know, and things. But I think that it gives some ideas when we talk to families, okay? And so I just say he was extubated on hospital day 3. So, you know, whatever, unless something horrible were to happen, but he could aspirate and die. But, you know, I don't think he's going to die within his 14 days of hospitalization, but, you know, they say he only has a little over a 30% chance of living independently at 6 months. I'm so sorry about the formatting here, but this other calculator is from the IMPACT trial. Again, this was internally and externally validated, and it's a prognostic model only for moderate to severe TBI. So the last patients were for any TBI, GCS 14 or less, but this is for the moderate to severe, which is considered 12 or less, in regards to their 6-month outcomes, or the Glasgow outcome scale. Over 9,000 patients were included, and this is the one that has 3 different models. And really, you just assess the model of what information that you have, okay? And again, this also can just be found, you just Google this, tbiimpact.org, and you can pop up this calculator. And so this is just a guy that I took care of in fellowship. He was a 20-year-old guy, MVC versus a tree. He came in actually not hypotensive, and he was not hypoxic either, but he had a GCS of 6T. His pupils were reactive and equal, and this CT scan here shows intraventricular hemorrhage, subarachnoid hemorrhage, and this makes it a Marshall class 2 CT, which you can just Google that too. I don't remember those offhand. It's just like a 1 through 5 grading of CT scan severity after traumatic brain injury. And again, I have to Google it every time. Hemoglobin was 13.8, glucose 126, and then here are his extracranial injuries. So I popped everything in, and this gives you this little graph here. And so overall, with the most information, his 6-month risk of mortality was 18%, and his 6-month risk of unfavorable outcome was 30%. So even though his CT scan looked quite a bit worse, he's younger. He was never hypoxic, never hypotensive, and so they say that he has a 70% chance of living independently at 6 months. And I think this was pretty good, because when we saw him in clinic at 4 months, he was eating, he had his trach decannulated, and all he had was some minor balance issues. I think he's 20, he was still living with his parents, but he had a pretty good outcome. Alrighty. So again, traumatic brain injury is a very broad topic. It's a little overwhelming, but we just talked a little bit about what we can do in the ICU, a little bit about the pathology, how we recognize and can treat intracranial hypertension. You realize we don't really have any data for what we're doing. And we talked a little bit about prognosis, and I would be happy to answer any questions.
That was really good.
I talked a lot and really fast, which is my standard. So.
Why haven't we studied CAPRA?
Yeah, good question. Sure. I mean, I think there's absolutely no reason that we couldn't. You know, I mean, I think that it would take a multi-center randomized controlled trial of thousands and thousands of patients, and so honestly, money.
Probably just came into play after all these other historical
and that's
studies.
exactly right. That's exactly right. Yeah.
We'll get lumped into the next big scale.
Yeah.
For those outcome scores,
Yeah.
do they recommend kind of a time frame that you evaluate that, or it's based off of the initial, right?
Their
So
initial vital
maybe
signs,
anytime.
their initial, yeah.
Okay.
So and I don't think that we necessarily have any like data for this, but like if somebody has bad TBI, what I tell the family is like, we just need to chill out for a few days, like 5 to 7 days, and sometimes it feels like we're doing nothing, and a lot of times we aren't, but we're in that active treating intracranial hypertension phase. Sometimes we're checking for seizures and those kinds of things. And then at about a week, I start pulling out these things and start talking to them about, you know, where are we going with this? And then at a week, usually say, unless they're like, absolutely not, like sometimes we'll get these young military guys who have made their wishes very clear because they've seen their buddies get TBI, and who'll come in like with a motorcycle crash or something, and their family's like, no trach, no peg, they've made it very clear, never, you know, and sometimes it's a little easier. But usually at a week I also say, let's chill out for another week, which I know it's hard to do because again, it feels like we're doing nothing. But then we start talking about the trach, peg, where are we going? But yeah, it's the initial vitals, initial GCS, and initial imaging that we use for the outcomes. Mm-hmm. Yeah.
So has it studied the craniectomy versus not doing the craniectomy? I mean, it was popular for a while and they quit using it and now they're back to it.
Yeah, so the official guidelines are to consider it. There really is not much evidence that it improves outcomes. The ectomy, I think the otomy has better, like just getting the burr hole of epidurals, I think that has a little better outcomes. But the most recent guidelines said that even putting in a bolt and changing and monitoring and all this stuff, intracranial hypertension, doesn't change outcomes at all, either. Yeah.
But it gives us something to do.
That's exactly right. It makes us feel better. And it's kind of counterintuitive, right? You would think like, well, seizures are bad, prophylaxis decreases seizures, but there's absolutely no evidence that prophylaxis improves outcomes, you know? Yeah. I feel bad for the neurosurgeons.
Catch-22.
What's that?
Catch-22.
Yeah, absolutely. Which is also why I think, like, with the Keppra, there's less side effects, and so people are more likely to just be like, we don't really know how much good this does, but it doesn't do a lot of bad, so, you know. Whereas Dilantin, you have to monitor it, and, you know, it has more side effects and things like that. So, yeah. Any other questions?
Thank you.
Yeah, thank you.
Concerns? Yeah. You can refer all questions to Dr. Holland. Martin.Holland at Providence.